All right. So today we're going to be talking about perioperative nutrition and spine surgery. At this point, you all know me. I'm Amber, spine fellows here. So the first thing we'll kind of start with is the pathophysiology behind malnutrition and how it affects our patients. In the most basic sense, malnutrition affects patients in two ways. It affects their ability to heal their wounds, and it also results in a decreased immune response. And those two factors ultimately lead to the development of surgical site infections and the morbidity and mortality that comes along with those. If you look at the healing process, it really occurs in four stages, that of hemostasis, inflammation, proliferation, and remodeling. And we all learned about this in medical school. But when patients are malnourished, certain stages of wound healing are affected, specifically the inflammatory and proliferative phases. So in the inflammatory phase, we see a prolongation of this phase with infiltration of macrophages and neutrophils to the site for a prolonged period of time. This ultimately leads to inhibition of the migration of fibroblasts into the wound. And the decrease in the fibroblast numbers, as well as their ability to produce their needed transcription factors, of which there are numerous ones. You can see all of those listed down there, including, importantly, VEGF, results in the inability of the patient to form proteoglycans, as well as collagen, and ultimately decrease neoangiogenesis. So you don't end up getting appropriate blood supply to your surgical wounds. And so this ultimately can lead to the inability of the patient to heal their wound. It's also associated with an increase in the immunodeficiency of the patient. So immune cells actually do not have their own energy stores. They obtain their energy from their surroundings. So if their environment is depleted of nutrients, they do not work well. And this has been shown in several different studies in the immunology realm. But it most specifically affects the ability of the body to produce and rapidly increase the numbers of thymocytes, splenocytes, and lymphocytes, particularly T cells. And so they have associated severe malnutrition to be associated with altered number of T cells and their ability to survive and proliferate. So this is a basic schematic looking at malnutrition in patients and the ultimate effect on their T cell levels. So they have decreased amounts of leptin, which ultimately decreases their T cell GLUT1 expression. This is an important factor that results in a decreased amount of the T cells themselves, as well as their ability to produce cytokines. And this decreases their capacity to be stimulated and respond to infections. And ultimately, this leads to a decrease in autoimmunity and an immunodeficiency. And so because of these two factors, these patients are at a significant increased risk for increased surgical morbidity. So the next kind of step is, how do we define malnutrition? Because in the literature, it can be defined in many different ways. There was a recent review article out of the JAOS that looked at malnutrition and defining it specifically in orthopedic surgery. So they kind of categorized this into three different types of methods. So one method is via serological laboratory values. And this is the most commonly used method that's both cited in the literature and kind of when you're just using it in the clinical setting, it appears to be the one that people use most often. In this review, they talked about total lymphocyte counts being less than 1,500, which we now know why that's important. Serum albumin levels as less than 3.5. I'll get into the discussion about albumin and prealbumin in a little bit, and serum transferrin levels. There are other studies that have looked at anthropometric measurements, and they actually reflect long-term nutritional changes, if you look at the literature, better than the serological values. The problem is they're harder to reproduce and it's time consuming to get them. You have to measure the calf muscle circumference, the arm muscle circumference, and then do this tricep skin fold test. And there is an unclear cutoff in the literature, but lower values indicate a worse nutrition. And there are also these standardized scoring tools that people have developed to try to make it more efficient for the evaluation. And a lot of these are actually in the geriatric literature. I'll go over a couple of them here. The other thing that they note in the paper but didn't really put in this table was that low preoperative zinc levels have also been associated with impaired wound healing, and the cutoff level you would use for that is 95 milligrams per deciliter. So these are the two most common types of definitions that you're going to see used when you start reading the literature and assessment of patients' malnutrition. This was a screening with specific regards to orthopedic surgery and the association between these two screening tools and the development of complications. This specifically looked at the NRS 2002 and the SGA, which is the Subjective Global Assessment. They demonstrated in the paper that at-risk patients, malnourished patients in both that qualified both with the SGA and the NRS had longer hospital stays, higher morbidity and mortality rates. You can see the odds ratios there. But what you'll see is that the NRS performed better than the SGA with odds ratio 4.1 compared to 3.5 and higher sensitivity and specificity. Although neither one really had a very good sensitivity level. Their sensitivity levels were ultimately pretty poor, but had better specificity levels and negative predictive values. And this is an example of the NRS screening tool. It looks at weight loss within the last 3 months. It also looks at BMI levels and takes into account the severity of disease. Remember, this was used in the orthopedic literature, but if patients met one of these criteria, either a hip fracture, major abdominal surgery, had a pneumonia, or a hematological malignancy, their scoring systems went up. For a more practical purpose, I found that this assessment tool was had the best sensitivity and specificity. So this is the mini nutritional assessment tool. It's used in the geriatric literature most commonly. It kind of takes into account all of a very global picture of the patient. So it does do anthropometric measurements, but pretty easy ones, weight, height, and weight loss, which can all be calculated pretty quickly. It's a global assessment. It relates to lifestyle, the patient's medications and mobility, and it takes into account the patient's own perception of their nutritional status. So it relates to the number of meals they're actually able to consume, how much food and fluid intake they have, and what is their ability to autonomously feed themselves. So it's a self-perception of health and nutrition. But what they found in the literature is that it actually correlates very well with serum albumin levels, better than the NRS 2002 and better than the SGA. If you looked at patients, they actually had a pretty good idea of predicting their own nutritional deficiencies. With regards to its sensitivity and specificity for correlating with serum albumin levels, it scored to be 96% with sensitivity, 98% specificity, and had a positive predictive value of 97%. So it actually worked pretty well and is used commonly for physicians in the treating geriatric patients in using it to screen for malnutrition. You'll also see this Rainey-McDonald Nutritional Index. It's a calculation based on serum albumin and serum transferrin levels. You can see the calculation there on the left. A 0 or negative score will indicate a nutritional depletion, but this has really not been validated in the literature, and so I didn't find it to be very useful. The next thing I thought I would touch on is this discussion between albumin and prealbumin. So if you look at the more early literature in the early 2010s, the albumin was the predominant serological test that was used. And what you're finding is that in the newer literature, the prealbumin is used more often. And the reason is that albumin kind of fell out of favor initially due to its long serum half-life. So its serum half-life is 20 days. So you're getting a picture of what that patient's nutritional status was within the last 20 days. And it has variability that can be related to factors such as hydration and renal status. So it's really not a good factor to use in patients who have chronic kidney disease. It's fairly inaccurate in them. If you look at prealbumin, it's a protein that's actually produced predominantly by the liver. So again, caution, knowing where these factors are produced is important because using it in specific patient populations can give you false decreases in their numbers. So in patients who have liver disease, prealbumin is not a great serological study factor. But it has the highest proportion of essential to non-essential amino acids in the body, and so it's a distinct marker of visceral protein synthesis. The great part about it is it has a very short half-life of 1.9 days. So you're really getting a picture of what that patient's nutritional status is in that moment, and it can be used as an early indicator of changes. This was a study that I found that looked specifically at prealbumin and its use specifically for surgical site infections after spine surgery. This was a retrospective review that looked at postoperative wound infections after spine surgery at University of Pittsburgh Medical Center. You can see all of the different types of data that was collected during the study. Ultimately, they had 83 patients that had prealbumin levels that were available at the time of the infection. What I thought was interesting was that their patient age was quite young, 56 years, and 71% were women. Many of these patients required multiple surgical debridements between 1 and 13, and 25% of these patients ultimately required a removal of their instrumentation with subsequent replacement. They had obviously extended hospital stays, which we know is common when people are requiring these debridements. And their prealbumin levels were all found to be below the norm or the cutoff. So 99% or 82 of the 83 patients had low prealbumin levels. You can see the distribution in this table here, where 24 of the patients had severely impaired, 32 of the patients had moderately impaired, and mildly impaired was 26 patients. After the patients presented with the wound infection and they were found with to have a nutritional impairment, the study then allowed for patients to receive some form of nutritional supplementation. So if patients were able to take an oral supplement, they were given protein shakes. If the patients were unable to have any oral intake, they actually gave them NG tube feeds. And then they followed the prealbumin levels on an outpatient basis, even after the patients were discharged. And the supplemental nutrition was continued until the prealbumin levels normalized. All the patients in the study maintained follow-up. They didn't have any subsequent additional delayed wound infections after the intervention. Now, there are some caveats to this study that I think are important to understand. So this was a study of only patients who had wound infection. There was no control group. And the reason that's important is because prealbumin is an acute phase reactant, and it will decrease in times of stress. So you can see on the right is the response of prealbumin to a stress response. So the body increases its catabolic processes, and the available amino acids are shunted to the synthesis of acute phase reactants. So that includes CRP, complement proteins, and fibrinogen. So instead of being shunted towards production of prealbumin, these acute phase reactants are produced. And so prealbumin levels will fall. And this is the hard part, that when the people who don't like prealbumin, and when they discuss it in the literature, the reason they don't like it is because they say, well, surgery is a stress, as is an infection. And so how useful actually is it in these settings? So people say it's better to use in a preoperative setting where you don't have any sort of stress response that has been initiated. This was a study that actually took and looked at all of these different factors, all of these different serological tests, and looked at it in regards to its ability to predict postoperative morbidity in major spine surgeries. So when we're talking about major spine surgeries, their criteria for that was instrumentation involving at least 3 motion segments. They evaluated serum albumin, prealbumin, total lymphocyte counts, and transferrin. They documented them both preoperatively and at postoperative day 5. And obviously they looked at all of these different potential postoperative morbidity factors, wound healing, duration of hospital stay, and correlated these nutritional markers with these complications. So things that they found, low preoperative lymphocyte counts and postoperative albumin and prealbumin levels could significantly predict the need for prolonged hospital stays in patients. Those were found to be significant in their study. They also found a significant correlation between postoperative low prealbumin levels and increased rates of complications. And they detected a significant correlation between the decrease in nutritional postoperative parameters and the rate of complications. And so the thing that they found most significant was that it was the degree and magnitude of the reduction of albumin and prealbumin levels that increased the complication rates. So the magnitude of the decrease in the nutritional status was a more important predictor of complications rather than a single nutritional parameter. And I think that that's important because that kind of addresses the issues with prealbumin and albumin with respect to their reaction to the actual stress of surgery. In this study, they were able to have a control group where they looked at what the normal drops were of these patients, and then looked at the patients who had ultimately developed complications postoperatively, and it was these reductions of albumin and prealbumin that they found were more related to patients who developed complications. So again, it was the magnitude of the decrease that was important. So why do we care as spine surgeons? Well, a recent ERAS recommendation, and we all know about ERAS, but addresses perioperative nutrition in their guidelines. This is their table that kind of looks at optimization of your patients and gives recommendations on everything from postoperative nausea and vomiting to preoperative nutritional status and supplementation. And they specifically address both the early oral nutrition and the perioperative nutritional supplementation. This is their recommendations, which I find are interesting. So patients undergoing a lumbar fusion should undergo a preoperative nutritional assessment. Strong recommendation grade, but low quality evidence. And the same was true about offering nutritional interventions. You should do it, but the quality of evidence is low. And what you'll find is that the literature is very good at describing what happens when patients have malnutrition. Even in the spine literature, I know we had previously discussed that total joint literature is really good about this, but actually there is quite a volume of studies, and I'll go through the kind of major ones that I found that looked at what happens to patients when they have malnutrition and they undergo a large surgical procedure such as the spine procedure. The first really good study was produced in 2014. This was published in a Journal of Spine Surgery. It looked at serum albumin levels in 136 patients and found it to be a independent risk factor for complications after elective spine surgery. The problems with this specific study was that it was a single institution study and it had pretty low sample sizes. So it didn't have great power. And so most people said, well, the issue with this, if you look at kind of like the editorial reviews of the paper, was that the smaller sample size in the malnourished, the power wasn't great enough to detect true significance. So in response to that, a study was produced in 2016 that looked at the American College of Surgeons National Quality Improvement Program. And the aim of this study was also to look at preoperative hypoalbuminemia and complications within the first 30 days. But this study had 4,310 patients included in it. The prevalence of hypoalbuminemia was about 4.8%, and it found a significant increased risk with wound dehiscence, surgical site infection, UTI, readmission, and longer inpatient stays. So you can see there the risk of wound dehiscence with low albumin levels was 5.8, SSI 2.3, UTI 2.5, risk for admission within 30 days 1.8, and longer inpatient stays 1.2. So not insignificant. And within the study, they were able to kind of provide certain patient populations that were more commonly affected by malnutrition. So age was obviously a significant factor. Patients from 70 to 79 had high rates of hypoalbuminemia, but even worse was the patients that were greater than 80. And I'll get into the reason why in a little while. But the other thing that was important was that insulin-dependent diabetics have a significant increased rate of malnutrition, even compared to non-insulin-dependent diabetics. So it was actually important to screen the patients and understand that if they had insulin-dependent diabetes, the risk of them being a malnourished patient was significantly increased compared to those patients who had non-insulin-dependent diabetes, which resembled that of the patients who did not have diabetes at all. And the other thing that we know is that there's a bimodal distribution of malnutrition based on BMIs. So it is very common in the low BMIs, obviously less than 20, but it is extremely common in the obese patients, in patients with morbid obesity greater than 50 or 45 to 50. And so knowing that these patients are malnourished despite their body mass index is an important factor to consider. So ultimately, they recommended that there is a significant correlation between malnutrition and complications. And next sets of studies should focus on decreasing the rates of adverse events following these procedures, so addressing the malnutrition. That is another study that came out in a very similar time, looking at 30-day readmission rates. You can see the Kaplan-Meier plot there. Preoperative albumin levels significant for being able to predict readmission rates in these patients. This is another study that looked at Medicare data in patients that were 65 to 80 years old, 1 to 2 level lumbar fusions, and malnourishment. It had 960 patients. They looked at lumbosacral spondylosis, degenerative disc disease, and spondies. Odds ratio of 6.16 in the elderly patient population of 1-year mortality, with a 4.24 increased odds risk ratio of 90-day medical complications, and obviously increased rates of wound dehiscence and surgical site infection. So can we put a monetary cost to this problem? This study specifically addressed that issue. So for every decrease in albumin levels of 1 gram per deciliter, there's an $8,000 increase in cost of care and an increased length of stay by an average of 3.7 days. I found their graphs pretty useful, their figures. So this was a multivariate modeling. You can see washouts and albumin levels. The coloration is the level of the albumin and the number of washouts. As the circles get darker, that is the lower the albumin level and the increased number of required repeat irrigation and debridements. And each additional IND was associated with about a $6,870 increase in cost. If you plot the total direct costs of treating these patients and look at what their correlation was with serum albumin, you can see that it highly correlated with increased cost. So what can we do to address the problem in these patients? This is where there is a paucity of literature. So I'll try to go over what I found was some of the best studies. This study we recently spoke about, and it's definitely got its problems, but it's about the only one that it looks at this specific problem in spine surgery. So this was a prospective randomized control trial. It looked at patients age 55 plus undergoing an elective primary lumbar surgery. It specifically addressed preoperative albumin levels. Intervention groups received nutritional supplementation in the form of a protein shake twice daily from post-op day 0 to 2 weeks post-discharge, and then the control group was instructed to continue their regular diets. Things they found were that they were able to decrease the rates of minor complications and wound healing complications within the first 90 days, but not within the index admission procedure. If these are the returns to the OR, so you can see on the left patients who had wound healing complications, the recommendations for their management. So you can see several patients in the control group required oral antibiotics, one requiring a formal IND, and only one patient in the intervention group requiring dressing changes. This is their return to the operating room. That's patient 4 that required a IND. So this study actually looked at clinical nutrition in older adults and tried to give treatment options and factors that influence the nutritional intake. And this was actually in the Journal of Clinical Nutrition. And this was for all patients undergoing any type of surgery, not specifically spine surgery. And it's important to address this idea of the anorexia of aging. So patients who are age 40 to even 70 years of age will have an average decrease of about 25% of their food intake. You can see the amount of kilocalories a day for men and women there. And the idea behind this is that it's caused by multiple different factors. So number one, there are significant social changes with patients who are getting older. Some are living alone, eating alone, so this drops the social aspect of wanting to eat. But there's also really important physiological changes that occur. One of the most important is with regards to their satiety. So this hormone CCK is a very it's considered your satiety hormone. It tells you that you're full, and patients who are older are much more sensitive to this hormone than other patients, and so they will feel less hungry and feel less thirsty and feel more satiated at an earlier point compared to younger patients. They're also dealing with slower gastric emptying and impaired gut function, and often dealing with decreased oral nasal functions, including impaired taste and olfactory sensitivities. Your taste buds drop their sensitivities by about 50 to 60% as you age past the age of 60. So foods don't taste as good, and patients have harder time just eating. They have poor dentition, poor mastication, and dry mouth. This can also lead to psychological problems such as depression and less motivation and to eat. So anorexia of aging is a really big issue, especially in our patient population, as they are, most of our patients are older. So the study specifically addressed the idea of oral nutritional supplements, or ONS. These are liquid foods that are used to improve the nutritional intake in older adults. And they have been shown to work. So this is a study that looked at nutritional supplementation in older adults and showed, did these actually help older patients? Did it improve their nutritional status? You saw some improvement in 26, 29, and 28% of patients, but significant improvement in the majority of patients, both in a hospital setting and in a community setting. So why is ONS better than any other form of supplementation in patients? This was a study that looked specifically at improving the nutritional supplementation in hospitalized elderly. Liquid supplements result in a quicker gastric emptying time, and so the total caloric intake is more likely to be improved. So it's important the volume that you give the patient as well as when it is offered to the patient. So liquid supplements should be given between meals, and they should be of low volume with high density. Number one, it increases the patient's compliance because it's easier for them to drink a smaller amount. And because it's a liquid supplement with high density, they are able to undergo gastric emptying faster, which allows them to still be hungry and want to eat their main meals throughout the day. So instead of the nutritional shake taking over their overall nutritional supplementation, it actually enhances the number of calories that they're intaking. So the ideal ONS, if you're looking at supplementing your patients, should be concentrated with a small volume and have a low satiation capacity with a short-term satiety effect in order to improve the patient's overall nutrition. So this was a study that looked at protein supplementation and actually looked at did it have an effect on the paraspinal muscle atrophy that we see after spine surgery. It was a randomized double-blind placebo-controlled trial. Patients were randomly assigned to a placebo, so they had a shake, but they didn't know that this shake didn't actually have any nutritional supplements in it, plus a normal diet with what is considered to be an appropriate amount of protein, versus patients who underwent a protein supplementation shake. And then they looked at the patient's cross-sectional area of their paraspinal muscles and their pain and disability scores after surgery. This is an example. I tried really hard to find examples of where people intervened and had specific protocols that they used. This was the protocol that they used for this patient population. So the amount of protein in the shake was about 12 grams for the supplemented, where there was no protein in the patients who were in the placebo trial. After 4 weeks of the protein supplementation, they did MRIs and looked at the cross-sectional areas of the multifidi and psoas muscles and demonstrated a significant higher cross-sectional area in the supplementation group rather than the placebo group. The people who were measuring were blinded to who had received supplementation. They also saw less atrophy in their erector spinae and quadratus lumborum muscles in the patients who had received the protein supplements. And this protein supplementation was negatively correlated with both pain and disability. So patients who had had the protein supplementation had less pain and less disability that met statistical significance. And so their thought was that these patients had better control over their, had better muscular control and thus had better, less disability and less pain postoperatively. In the joints literature, there's a lot of different articles. This was the best one that I found that had a specific protocol that they used to supplement their patients with and gave specific recommendations. So this was in geriatric hip fractures. So unfortunately, they weren't able to preoperatively optimize these patients, but they had a control group and an interventional group. The control group was given an IV infusion of human albumin only postoperatively. The intervention group received a enteral nutrition powder, and then at post-op day 3, they carried out a blood test to check their serum albumin levels. If it had resolved and come back to normal levels, they stopped the treatment. If they didn't, then they gave them this nutritional powder, which is a form of Ensure. You can see this was recommended by their nutritionists. With specific recommendations on protein and carbohydrate intakes as well as fat intakes, and they recommended it 3 times per day. For both groups, the treatment stopped only when the hypoalbuminemia was corrected or they had a decrease in their wound effusion. This is some of their results. So hemoglobin levels were not affected, total lymphocyte counts were not affected, but they did see significant increases in the albumin in the intervention group. This was correlated with decreased complications after surgery. They saw less wound complications, less surgical site infections, less prosthetic joint infections, and less readmission rates as well as hospital stays. So they found it to be effective in producing better outcomes for their patients. So if I could give final recommendations on, what we can do for the patients. So assessing their preoperative nutritional status is critical. Getting a total lymphocyte count, transferrin level, perhaps using, if you were to do a study, I think the MNA would be a good questionnaire to use, just given its high sensitivity and specificity. The literature varies on the recommendations of albumin and prealbumin, and I think ultimately what that means is you have to understand your patient. If it's a liver disease patient, prealbumin might not be a good idea to get. Albumin isn't a good idea to get in chronic kidney disease patients. Both have shown to be very highly correlative for predicting postoperative wound complications. Understanding that prealbumin is highly affected by stress responses. So if your patient recently had an infection, it's probably not a good idea to use it because it is going to be decreased. But if you've resolved that infection and it's been a couple of days, it would be an appropriate thing to use. And you should understand that when you're using them in the hospital setting, it is their magnitude of decrease that is important to look at, not necessarily the overall value. Levels that fall below should have nutritional supplementation. It's pretty clear that people do more poorly if they are malnourished. The paucity of literature, though, is in identifying a appropriate preoperative and in-hospital and postoperative regimen, and that's not yet been developed. Things to know that are important is that ONS is best, especially in older patients. You should be giving it in between their meals. You should not be giving their nutritional supplementation with their meals. You're actually not improving their nutrition at all. It should be an extremely low volume shake, no more than 60 cc's, and it should be an extremely high calorie, high protein shake. And these were kind of some of the recommendations I was able to kind of glean out of the literature. The last thing I wanted to say is thank you to everybody. This is my last presentation. I've made some great memories here and great co-fellows, Jay and Cameron. And this is us jumping off the stratosphere in Las Vegas at the very beginning of our fellowship. Thank you to Dr. Malone for the wonderful Tuesday clinics and getting wonderful lunch. And these are our memories we made at Banff, which was a wonderful experience for Cameron and I. I really appreciate it. And then from our latest party, thanks for Dr. Mundis showing up despite undergoing surgery. That was pretty impressive. And Dr. Bruffy for always being there for us and always being a happy face to see in the morning and supporting us. And then Cameron is a most amazing person. I have made a very wonderful friend and colleague that I'll trust and keep in touch with for the rest of my career. And thank you to my family who has supported me throughout this entire process. Thanks, guys.
Amazing, Amber. That was a fantastic talk. I want to say a few things, though. I think nutrition is really, really poorly delivered in the United States. I don't know if you happen to take a look at the FDA's revised food pyramid, but frosted mini wheats, which has milled corn, sugar, and palm kernel oil, is the #3 recommended food. In addition to the top recommended food are Honey Nut Cheerios, and then also up on there is egg substitutes, fried in vegetable oil. I think in Europe, half the stuff that we have on our shelves here are illegal with all the food colorings and additives. So I think sometimes it's not just what patients should eat, but what they shouldn't eat. And if you dive a little bit deeper into our patients' nutritions, particularly the ones that fall into the frailty scales, they're probably drinking sodas or diet sodas, and their diets aren't very rich in the things that we need. So I think that's an area that needs to be investigated much more in depth.
I agree.
All you got to do is pick up a Stephen Gundry book. He's one of the pediatric cardiac surgeons in the UC system, and really get sort of an enlightenment on sort of inflammatory foods and all the garbage that's been shoved down our throats that's really bad for us. And sometimes it's probably easy to avoid these chronic illnesses or actually turn people around by just starting with a good nutritional shakedown.
Right, and I think that's kind of reflected in that in the obesity patient population, not in just them, but like it is reflected in that. They have very high BMIs, but they actually have the worst nutrition. They had worse nutrition compared to patients with a BMI of less than 20. So what people would classically be described as being malnourished, they were significantly higher than any of those. If you looked at that graph, it was not even close. So
yeah, exactly. I mean, we could have a whole day, half day, full day conference just on like what our patients should be eating and what they shouldn't be eating, because clearly our FDA has like a very divergent agenda in what they're telling people is good to eat. Also up there is canned pineapple and heavy syrup, Lucky Charms. I mean, these are terrible. These are terrible things for people to be eating, you know?
yeah.
We should all have a jug of green juice, just like Dr. Eastlack and carry around. All right. Well,
Great
thank
talk,
you.
Amber.
It's been an absolute pleasure. You're wonderful. Great to see you. And I'm looking forward to getting you in the OR and go over some 7D stuff.
That'll be awesome.
All right. Bye.
Bye-bye.
All right. Have a great day, Amber.
Good job, Amber. That was awesome.
Thanks, guys.
Yep.
Thanks, Amber.
Amber.